with an aspect score 8, 9, without any concomitant disease too much. The glucose is well controlled. I tend to use actually 2/3 dose of coronary literature. I give a 2.5 milligram of tropoban, and then followed by 8 hours of infusion. Whenever I perform a permanent stent, I just do the DynaCT or expert CT to see what's going on the brain, to see if there is a enhanced contrast, if there is an enhanced contrast extravasation or not, if there is any bleeding or not. If there is no, then I tend to give some tropoban infusions in this kind of patients. But I act actually for all patients for individually. I do not have any kind of strict algorithm. Sometimes if I see too much contrast enhancement in terms of Hans per unit, like 100 Hans per units of contrast in the basal ganglia region or other regions, then I reverse the heparin. I tend not to put intracranial stenting, permanent stenting. What I do is, if I have to put the stent, perform a stent, I do a DynaCT or expert CT, brain status. If it's okay, then I put the permanent stenting, and I may give tropoban. If not, I try to be less aggressive.
Yeah, okay.
Thank you very much.
Now, I think we have to move to the next speaker, Professor Dr. Mahar. Thank you, Dr. Oskan. And
thanks a lot, Osama. Thanks for excellent webinar.
Then we move to the next speaker, Professor Dr. Mahar Saqqur. He is a clinical professor of neurology in University of Alberta, Canada, and his talk will be on the continuing the dilemma of the difficult situation in recanalizing acute ischemic stroke patient. The intracranial atherosclerosis is one of them, and he will give us the topic in TCD evaluation, transcranial Doppler evaluation in intracranial atherosclerotic patient. Please, Dr. Mahar.
Thank you very much, Dr. Osama. You hear me well, huh?
Yes,
I'm
we
just
are.
I'm putting on the slides on my laptop, but I'm talking from my iPhone. So if you don't hear me well, just let me know.
The sound is very far away. You can.
Hello, you hear me now?
Yes, please.
Yeah, you hear me now, huh?
Yeah.
Very good. So I have nothing to disclose. So, what I'm gonna touch in this talk actually about the role of TCD in diagnosing intracranial atherosclerotic disease, and how does it play a role in defining the mechanism of stroke in the presence of intracranial atherosclerotic disease. So, as we know, like in general, 10% of the ischemic stroke mainly occur due to intracranial atherosclerotic disease. And as you know, this is very much common in Asia, Black populations, and Hispanic, more than the Caucasians. Interesting, like just what Dr. Oskan mentioned, that he doesn't see it quite often in Turkey. So that's very interesting. Like, I wonder if it makes difference if you look at the etiology of atherosclerotic disease in Istanbul versus if you look at it in Hatay, for example, or Gaziantep. So you might find a difference. It's probably the northern part of Turkey, more of close to European side, isn't it? Which is very interesting. So, but it's more of Asians, Black, and Hispanic populations. So clearly, like all the criteria on transcranial Dopplers for atherosclerotic disease, they find more than 50% stenosis associated with the velocity change on TCD. However, the significant narrowing very much comes with more than 70% stenosis, where really intervention needed. But more than 50% were more of started having medical treatment. More than 70% still we do the medical treatment with combined antiplatelet for a short period, 3 months, high dose statin. Then we might ought to use Blavix and aspirin or continue on the combinations. Varies, still the jury is out. But really, what we focus on more than 50%, and we are concerned about more than 70%. You look at the second slide. I'm trying to look at the second slide. Yeah, okay. So the TCD very much rely in looking at the intracranial atherosclerotic disease through the temporal window. Through the temporal window where you go 100% power, you aim at the temporal bone to look at the vessels, and you get the power M mode. The M mode, your roadmap to get proper spectrogram. So you might inseminate the MCA, ACA, terminal ICA, BCA, tail of the basal sometimes. So you very much have a good look at the intracranial vessels through the temporal window. And the markers which we use on transcranial Dopplers is very much the mean flow velocity, which is peak systolic velocity plus end diastolic velocity times 2 divided by 3. So very much like mean blood pressure. But the mean flow velocity is our markers for intracranial atherosclerotic disease. The higher the velocity, the more stenosis it is. And I will go over that and explain that to you. But remember, the mean flow velocity is peak systolic plus end diastolic times 2 divided by 3. And if you understand this figure, I think you understand how TCD plays a role in diagnosing intracranial atherosclerotic disease. It's called the Spencer curve. So the x-axis here, you have the lumen diameter, and the y-axis, you have the velocity. So you have 3 lines: the blood flow, and two lines: the velocities and the blood flow, and the lumen diameter. So in general, the lumen diameter in the MCA range between 3.5 to 4 mm. That's where you have a normal velocity, normal flow, as you see. What's happened when in the presence of intracranial atherosclerotic disease or vasospasm or vasculopathy or any form of vascular narrowing, you form like cocaine-induced vasculopathy, intracranial atherosclerotic disease, intracranial arterial dissection that led to arterial narrowing, all these forms that decrease the lumen diameters. And what's happened in that stage, the velocity increase to maintain the blood flow in a normal range. So the blood flow needs to be maintained by increasing the flow, the velocity. And that's where we start seeing the high mean flow velocity on transcranial Doppler. So that's where you started, the curve of the velocity go up, the blood flow maintained, the diameter drop. Now, this is not all the story. So once the lumen reach critical point of 1 millimeter or less, then the velocity scream very, very high, very high. So the curve between lumen diameter and velocity, it's very much correlating. The high velocity, the lower the lumen, the lower the diameter of the lumen, until one point, which is the peak. Then after that, as the lumen drop, the velocity is very much started dropping. And that's where the blood flow start dropping and patients become symptomatic. So it means if you use the transcranial Doppler to diagnose and monitor intracranial atherosclerotic disease, you don't rely only on a high velocity. The blunted flow, the drop velocity, it's indicative of decompensations and a late stage of severe intracranial atherosclerotic disease, close to near occlusions or occlusions. It's very important to understand this figure, and that's all what explained the transcranial Doppler findings in intracranial arterial neuron. So, and when we look at the TCD, when you look at the transcranial Dopplers to define intracranial atherosclerotic disease, the beauty of TCD, you can monitor the MCA, ACA, terminal ICA. This is a case of severe intracranial atherosclerotic, not intracranial atherosclerotic, this is severe vasospasm due to subarachnoid hemorrhage. So as I mentioned, you rely on a high velocities exceeding numbers. In the mean flow velocity here, 266. In the terminal ICA, 169. And in the MCA here, 115. So that vascular narrowing correlates with two things on TCD: the high velocities, and on the power M mode, you pick up this black hole, which is indicative for flow disturbance, as you see here, the black hole. So the drop in the signals on M mode is called black hole. It's indicative of flow disturbance on transcranial Dopplers, and that correlates with a high velocity on spectrogram. I'm trying to just move the on. You have to move the slide from the Zoom. Okay, good. So now, how do you diagnose stenosis or intracranial disease on TCD? I will go over the WASID criteria. In the WASID trial, they use more than 50% stenosis. And in WASID, they use the SONIA trial, which is the SONIA TCD criteria. They use the cutoff of velocity of more than 100 centimeters per second for the MCA. Terminal ICA, ACA, they use the 90 centimeters per second. Vertebral basal BCA, 80 centimeters per second. And what they found, the TCD has a high negative predictive value compared with an MRA. So TCD, compared with a cerebral angiogram, but they have two arms. They have the transcranial Doppler and the MRA arm. So the MRA arm and the TCD arm. So the negative predictive value of the transcranial Doppler is 83%. The positive predictive value is 55%. What does this mean? It means if you have a high negative predictive value, you have a normal velocities, that's very much exclude intracranial atherosclerotic disease or intracranial narrowing. And whereas the positive predictive value is a moderate 55%, it means if you have an abnormal TCD, you need to confirm it, and I recommend you confirm with the CT angiogram or MR angiogram. I'm more lean into CT angiogram because it's a better accuracy with the catheter angiogram. Now, if you look at the SONIA trial done by Feldman, and really the negative predictive value or positive predictive value varies based on the cutoff velocity. You see? So it's a slight trend there in the negative predictive value and increase in the positive predictive value as you increase the velocity. So for example, if you use the transcranial Doppler mean flow velocity 200, that enhance your positive predictive value to 60%, but drop a little bit your negative predictive value from 0.86 to 0.81. And a different cut for the ICA and for the vertebral artery and the basal arteries. So very much it's the expenses of the negative predictive value on the expense of the positive predictive value, or the vice versa. I hope you hear me well, huh?
Yes, yes, we are here. Yes.
Yeah.
Okay.
Because I'm talking from my iPhone.
Yeah.
So the next thing is we went ahead, Limon, and actually I was part of this study. We looked at the velocity criteria for intracranial stenosis, and we revisit them based on transcranial Doppler in comparing with the gold standard of the cerebral angiogram. And we came with a very interesting criteria. I will share it with you. So we decided to look at the SONIA velocities criteria for more than 50% stenosis on TCD for intracranial atherosclerotic disease, and determine the cutoff that would be offering good accurate parameter for screening more than 70% for intracranial stenosis. And what we found, using the SONIA criteria, as I said, for mean flow velocity more than 100 for MCA, ICA, ACA more than 90, vertebral basal more than 80, we reached a good sensitivity and specificity. But again, take that with a grain of salt, because this is an expert sonographer, expert hat. So this is not, doesn't describe the real of the world, the real pictures of TCD. So so we have a very good sensitivity and specificity if we use the criteria more than 50% based on SONIA criteria. However, for velocity more than 70, for stenosis more than 70%, severe stenosis like this case, more than 70%, in the anterior vessels, the cutoff we use 128, in the posterior vessels reach the cutoff of 119, and we reach a good sensitivity of 78% and excellent specificity of 96%. For anterior circulations, for posterior circulations, very much 100% and 99%, with overall accuracy of 97%. Again, this is with an expert hand in ultrasound. Now, what we did here, we looked at the ratios of the stenosis to the pre-stenosis velocity, the velocity at the stenotic side to the velocity before the stenosis. And we find the ratio more than 3 has an excellent correlation with intracranial atherosclerotic disease. So this is looking at the ratio, at the relative increased velocity. And again, as I mentioned, you care for if you have an intracranial stenosis more than 70%, which is significant stenosis. That if it fails medical treatment, you have no option except to stent. And still the stent is not proven. And then still there is some trials going on. So really more than 50% medical treatment, more than 70%, that's where you start thinking, if patients fail the super medical treatment, what else I need to do? And by using the stenotic to the pre-stenotic ratio of more than 3, you really enhance your sensitivity from 78 to 90%. However, the specificity has not been changed. Give you an example here. This is a case of 58% stenosis in the MCA. The velocity at the stenotic site 104. At the before the stenosis, before the stenotic site is 43. The 104 over 43 ratio is 2.3. It's less than 3. So that's consistent with less than 70% stenosis. This is a moderate MCA stenosis. This is a severe MCA. Severe MCA stenosis. And again, the velocity at the stenotic side 188. Before the stenosis 53, the ratio 3.5. This is consistent with more than 70% stenosis. So this is our developed criteria on TCD for intracranial stenosis. Another case in the posterior circulations, you have a mid-basilar stenosis, more than 70%. I mean, easily I would say this is easily 80% stenosis. The velocity at the site of the stenosis is 33. Before the stenosis 33, if you look at the ratio 133 over 33, it's 4. That's consistent with more than 70% stenosis. I'm sorry if I'm very fast, just let me know. Dr. Osama, is the yes. Good or
yes, we are catching
now. Now I'm gonna shift gear here. From the diagnosis of intracranial atherosclerotic disease to the mechanism of stroke in intracranial atherosclerotic disease. Now, I'm just gonna open the questions here.
Okay.
Does everyone believe the atherosclerotic disease, stroke in atherosclerotic disease, is an embolic phenomenon? I don't. I think part of it is hypoperfusion.
Yes.
So it's either hypoperfusion or an embolic. And really, if you look at it, the management will be different between playing with the blood pressures, hydrations, and orthostatic drop in the blood pressures and all these things, versus embolic, enhance the antiplatelet, and all these things. And that will help, Oscan and our interventional guys to intervene or not. So I will present a series of cases where we actually collect them and publish them, where we prove the concept that intracranial atherosclerotic disease can lead to hypoperfusion syndrome. It means a blood steal phenomenon rather than being an embolic phenomenon. This is an interesting patient, as you see. Actually, what he has a right vertebral stenosis, as you see on the right side, and left vertebral artery is very much absent. So has a severe intracranial posterior circulation intracranial atherosclerotic disease. So the left vert is occluded, the right vert is severely stenosed. Okay. Okay, so he keeps having brainstem symptoms of ataxia, double visions, dysarthria, unchanging position from lying to sitting up. So what we did a monitoring of the bilateral posterior circulation of the right BCA and the left BCA, and then lying down positions. Then we sit him up, and we did demonstrate through the temporal window that the flow very much disappeared from moving him from lying to sitting positions. So this is a typical hypoperfusion syndrome due to severe intracranial atherosclerotic disease. And in this case, I mean, no matter how strong you go on antiplatelet or anticoagulations, really it's more of hemodynamic. And I mean, I might ask my interventional colleagues to intervene on this, on the right vertebral artery, if I feel in maintaining his blood pressure high, if I feel in preventing symptoms with the traditional medical management. Another interesting case. This actually, this is one of those fascinating cases. Patients. This patient referred to me. Actually, he was like he's the ambassadors of Canada in Pakistan. He was very much sent back to Canada and end up seeing my colleagues who is a Pakistani physician, and he referred them to me to make the things interesting. So what he had, every time he had a neck extension, he very much get dizzy, vertigus, dysarthric, then he black out. So, and what I don't have is X-ray of the neck pictures, but what I can tell you, he had a hypoplastic, right vertebral artery is very hypoplastic, and the left vertebral artery is very much obliterated by osteophyte in the neck. He has a huge osteophyte, very much bending on his left vertebral artery, and the right vertebral artery very much hypoplastic. So every time he goes to neck extensions, I did monitor his bilateral BCA. His flow very much disappeared in neck extension and become symptomatic. Then when he straightened his head, flow re-established in the bilateral BCA. So we collected all these cases and got it published in 2010. But what demonstrated here, that TCD not only as a diagnostic tool of the presence or absence of the intracranial atherosclerotic disease, but it play a role in defining the mechanism of stroke in the presence of intracranial atherosclerotic disease. Now, shifting to another role, which is emboli detection in the presence of intracranial atherosclerotic disease. And by putting the frame there, the transcranial Doppler aiming at the MCA, you can monitor for an hour or two. Hugo Marcus is coming with a head frame, with a glasses head frame that can last for 12 hours. So in the future, we'll have the same like we have a blood pressure monitor and Holter monitor, we will have an emboli monitor. And there is several indications for emboli monitoring. And one of them is the presence of intracranial atherosclerotic disease. And we already have a criteria for the presence of emboli on TCD, and the M-mode help us in tracking the emboli to be sure it's a real emboli, not an artifact. And if you're interested, that is the criteria by being unidirectional on spectrogram, has a chipped or pop sounds, a typical more than 3 decibel higher than the background, less than 300 millisecond iterations, and random occurrence. And we have the criteria on M-mode. And this has been established that it's very helpful in monitoring the distal to the stenosis in the intracranial disease. So if you have an MCA stenosis, I advise my sonographer to monitor the M2. If you have the stenosis in the M1, I monitor the distal MCA in the M2 or M3. If you have a terminal ICA, I monitor the M1. If you have a mid-basilar, I monitor the distal basilar. And this is critical. You need to monitor distal to the stenosis, not at the stenosis. And this is an artifact, and this is a real emboli. And this is the new criteria of TCD on M mode. I'm gonna pass it quickly, and I'm just gonna be so. If you pick up in this study, they looked at all patients with MC stenosis, and they picked up positive microembolic signals in 1/3 of them, 36%. And the interesting thing is, 25% of MC stenosis, very much the emboli completely disappeared at 6 months with treatment. So what you find here, like for an example there, where this is an MCA stenosis with a microembolic signals monitoring that can help you in maximizing your medical management. From adding aspirin to Plavix, maintaining the aspirin and Plavix, when you will take the aspirin, add Plavix, and etc. And now we are entering into the era of DUAC, and we don't know if it has any role in the intracranial atherosclerotic disease, but I see that this tool can be helpful in individualized medicine. So my conclusion, I think TCD remains a cheap bedside screening tool for intracranial atherosclerotic disease. You know, with a standard screening protocol, you can use the Sonic mean flow velocity criteria to define more than 50% stenosis. If you're keen on defining more than 70% stenosis, I advise you to use the actual velocity to the pre-stenotic area velocity. That's what we propose in our paper, to detect more than 70% stenosis, and use the stenotic to the pre-stenotic ratio of more than 3, and has an excellent agreement with the cerebral angiograms. You know, the TCD not define stenosis, but it helps you defining the mechanism of stroke by being embolic or hypoperfusion, and definitely help in management. And the new development, which I don't put it here, I will looking to see you in August. I will present it. There is a neurolytic machine where it's very much hands-free. You monitor you do transcranial Dopplers with not being operator dependent. And that's it. Thank you very much for giving me the chance to present.
Thank you, Dr. Mahar, for your interesting talk and very comprehensive information. I think we can have 2 or 3 questions for Dr. Mahar from the audience. If anyone have any question, he can raise his hand. I think there is still an experience regarding using Zoom, but we are improving with each session.
Yes.
So I have a question for Dr. Mahar.
Yeah, fadal.
I know you are one of the main researcher in the CLOPEST trials with each different phases, and I think you have some consensus about any indirect or direct clues about the intracranial atherosclerosis pattern of transcranial Doppler after recanalization with TBA. If you have any comment on this topic.
So if I have understand the question, Dr. Usama, what's the accuracy of TCD? Yeah.
I mean, when you have some cases with with intracranial atherosclerosis, which received TBA and had succeeded recanalization, you can find special findings during this situation from the transcranial Doppler point of view, which can be helpful in diagnosing intracranial atherosclerosis in a retrograde fashion.
I got you. Yeah. So that's interesting. That's very interesting. So in general, as you see, the intracranial atherosclerotic disease lead to high velocities. You know what I'm saying? So that's a focal narrowing. At the same time, post recanalization, after like recanalization post TBA, you get a high velocity, which is very much TB4, like a grade 4 velocity, name it TB4. The way to distinguish if the velocity persistently high 24 hours later, that's more of intracranial atherosclerotic disease. If the velocity normalizes in 24 hours, so from TB4 to TB5, that's more of recanalization flow. I hope I answered your question.
Yeah. Yes, I think it's a very interesting idea. If we could also combine transcranial Doppler during the recanalization in the CAST lab, and we can get this information, which will be helpful for judgment or in life judgment during the mechanical thrombectomy, either to choose putting stent, permanent stent or not, if we combine the transcranial Doppler with mechanical thrombectomy.
Of course, inshallah. Yeah. I think the future is with the neurolytic machine, which will be very portable. You can put it around the head frame of the patient and get frequent TCD, very much like ECG.
Yeah, okay. Thank you, Dr. Mahar. And now we can move to Professor Dr.
Okay.
Okay يا دكتور عبد اتفضل حضرتك.
Okay.
اتفضل يا بيه.
Dears,
Yes.
how are you for all?
Yes, we are hearing you.
Hope to be fine. Yes, I will present it my topic.
Past